This program aims to find solutions to your medical queries. It seeks answers to common health problems that have been hounding you. We will help you out in finding answers to your medical concerns. Good evening, everyone. I'm Angel Jacob, and this is MedTalk, your weekly on-air health consultation here on 9TV.
Obvious changes happen to one's body as we age.
When people gets older, a lot of things degenerate in our body, right? So that includes the parts of the eye. The lens becomes cloudy with age, gradually. The retinal structure degenerates, becomes thin, becomes weak. That's when we have degeneration of the macula.
One such change may come in the form of deteriorating eyesight, which is one of the primary causes of blindness in the country.
For me, the three most common eye diseases that usually we screen among elderly patients are the following. Number one is the cataract, formation of cataract. Number two is the age-related macular degeneration. And number three is glaucoma.
Cataract affects over 1 million Filipinos, particularly the elderly. Another concern for the elderly is age-related macular degeneration, or AMD. In this case, your once sharp and reliable vision slowly deteriorates, affecting your ability to do daily activities such as driving, reading, and writing. While many lifestyle choices may avert or delay the onset of these age-related eye conditions, it is advisable that when one reaches their 40s, regular checkups and routine eye examinations are a must.
Starting at the age of 40 years old, we advise you to have at least an annual or biannual eye examination. That's when we screen for eye diseases that are affected by age.
How safe is a cataract removal operation? What macular degeneration treatments are currently available? Find out the answers tonight on MedTalk.
And joining us tonight is Dr. Ricardo Tobias Papa, an ophthalmologist from the Medical City. Also with us tonight is Dr. Rory Go. He's also an ophthalmologist from the Makati Medical Center. You may join the discussion by calling our hotline at 548-4678. Good evening, doctors. Welcome to MedTalk.
Good evening.
Tonight's topic is age-related eye conditions. So at what age are eye conditions more prevalent, or do they happen when you're still young? How does this happen, doctor?
Maybe what we can best do is we just, in the spectrum of life, we sort of subdivide it from birth to as young, and then as we grow older, and then as we age. Okay. So definitely there are changes in the visual pathway. As what we know, once the baby is born, the vision is not yet fully mature. Mm-hmm. Okay, so it takes almost up to 7 years old. That's why by convention that the vision is what we call normal or mature. Beyond that, it's further growth, further training, further sharpening of the vision, depending on the lifestyle. If there's some genetic factors, there will be some changes. Then later on, depending on the food that we eat, things like that, there will be some changes again. So per se, there will be some major changes as we grow old. Mm-hmm. So I would think that Dr. Papa can expound on it.
Okay, so what are these major changes as one goes old?
Well, once you hit 40, that's when presbyopia starts. So a lot of people, siguro, you're gonna have difficulty reading and focusing on near objects, and that's basically what presbyopia is. So after that, if you have certain systemic conditions, then they can start to manifest in the eye, like diabetic retinopathy, things like that. And then further on, when you get older, 60s, 70s, that's when you get into cataracts, and older, you can get macular degeneration. So those are the more common eye conditions that we see.
So the more common eye conditions past the age of 40.
Yes.
Okay. So talagang when you hit your 40s, should you expect that either one of these conditions will happen to you? Given, I mean, you're healthy, you know, in your 30s, your 20s, your vision was okay.
Well, kasi presbyopia and cataracts, they're degenerative conditions. So what it means is that when you age, you will get those. So everyone, no one is immune to being presbyopic. Everyone will get cataracts. However, with diabetic retinopathy, you will get that siguro only if you're diabetic. And macular degeneration, not everyone will get that as well.
Okay. So you have your eye models with you. Let's talk about first the normal function of the eye before we go to the more common eye conditions. So, Dr. Go,
So
start with you?
basically, if you imagine the eye as literally a camera, okay? So it gathers light. So this is your camera. There's a front part, a back part. It gathers light through the cornea, through our lens. It controls the light through our iris. So in our case, it's a brown-colored iris, no? Depending on the rays. Concentrates and focused by the lens itself, which is perfectly centered, and focuses all the way to our retina. So the retina, as what we say, is our film, or right now, what we call our CCD. Okay? So we're born with a good number of healthy CCD so that we can have good, sharp pictures, provided all of the light is focused properly.
Okay.
So that's basically what it is. So when you have changes, as what you said, you can have changes from the front to the middle to the back, or anything in combination with it. So that's basically it. So as what you said for presbyopia, it's the change in the elasticity of the lens, so thereby difficulty in focusing. So that's when you see patients are having a hard time reading what is a price tag or the menu. They pull it out further.
Yes, that's presbyopia.
That's presbyopia.
Okay.
Then when you have cataracts, wherein the lens starts to opacify, so you need a brighter amount of light, or sometimes you would, no matter what you do, is you keep on changing a refraction, and you still don't see a lot better. Okay, so those are the basic simple things. Or if you have a problem in the cornea, wherein the most common problem would be dry eyes.
Okay.
Okay, so if you have dryness of the eye, there's some slight blurriness, you have discomfort, you have that eye redness feeling, you have that blinking of every few seconds, and you feel tired, sometimes to the point of headache. That's what Dr. Papa said. So that's basically how a normal eye should be.
You mentioned dry eyes, presbyopia. These are some common eye conditions. So let's talk about that. Let's talk about let's talk about all of those mentioned, no? The presbyopia, you have your dry eyes, you have your maybe even being colorblind. Is it a common eye condition, Dr. Papa?
Colorblind. Well, it's we don't see it regularly, but only because I feel that patients really aren't screened for color blindness. The only times that we get patients who are asking for a color vision test are for those whose employers require them to have a color vision test. So usually seamen or those in the airline industry where they need to see, specifically the different colors. And but otherwise, let's say in a normal testing of even preschoolers, grade schoolers, it's not a requirement to have a color vision test.
Okay.
So it's probably underreported.
Okay, so you mentioned preschoolers, grade schoolers. Let's start with them. Since, it's age-related eye conditions. No? In grade school, in preschool, when the kids start looking at the blackboard, reading, when they start writing, are there certain eye conditions that are common to that age group? Dr. Papa?
Usually for kids, it's usually error of refraction. So what you want is to make sure that both eyes are seeing fairly well. Kasi a lot of times patients will come in, the parents do not know that one eye has a problem. So, and it's because there might be an error of refraction in one eye, but the other eye has normal refraction. It's best that the kids are seen early, and then to check for their refractive error and correct it if possible.
What are the symptoms of a child who has error of refraction? That, sometimes it's not the parents who notice it, but the teachers. So maybe we can give tips to our teachers so that when they notice that maybe the student may have an error of refraction already.
Perhaps the most common would be, number one, they would be copying things that are different. Okay, they see it and they think they saw it like a letter P. Instead, it was F. So they write. And it's a constant mistake. Number two is when you notice the kids would squint. Okay? Or when they copy, they do this. Things like that. So, they're trying to exert effort to focus. Or like when at home, when the parents or the maids or the yayas would see that they watch TV, they will have a preferential tilt. Or they do this.
Okay.
Because it's like I don't know if you call it a stare or a glare. It's something like this where it's stare. So you're angulating your eye to a certain point that you can see better. So in those simple things, simple cues, you can already suspect that something is not right in the visual pathway. Okay, in the visual axis. So we can have them scheduled and seen either on their free days, okay, and that's why we advise patients and parents that do it before their school or during their sem breaks or their Christmas breaks so that at least they'll be seen twice a year, something like that.
So something like that can be corrected in
Yes.
childhood and will not happen again in adulthood. Is that correct?
Well, the error of refraction changes. The eyeball of the child will change. It will still grow up to about 21. So if the eyeball grows, the error of refraction can change. It can go either up or down. So that's the reason why your ophthalmologist will recommend either twice-a-year visits or yearly visits, just to make sure that the error of refraction is still the same, or if it needs to be changed, then they will do so.
Treatment for a child with error of refraction. Does the child need glasses? Does
most
the child
common is
need
glasses.
eye drops or what?
The most common would be glasses, and we tell them to wear it most of the time, especially if you are nearsighted, and if you're looking at your blackboard, you really have to wear the glasses. If not, you'll only be able to see your book or your iPad. That's it. Okay, so we tell them. Okay, some parents would say, "Doc, do we have to let them wear it every time?" It is always advisable to let them wear it every time, regardless of the grade.
Any other childhood eye condition that parents, teachers must watch out for? I was doing my research and I came across lazy eye that infants and children have, or this condition is only common to that age group. Can you please tell us about this lazy eye?
Lazy eye, it's when basically the eye starts to deviate. So instead of being normal, meaning it's able to focus directly at something, it starts to go either in or out. And there are many causes of a lazy eye. One of them can be because the eye is amblyopic.
What do you mean when you say amblyopic?
Oh, sorry. When amblyopia is a term that refers to basically the eye cannot function anymore. Structurally it's sound, but it cannot see as well. So this happens, let's say, as I mentioned earlier, one eye has good vision because it has no error of refraction, but the other eye, let's say it has a grade of maybe, a very high grade, -5, -6, and it wasn't corrected early on. What happens is the brain of the child will tend to use the other eye and not use the poorer eye. So the poorer eye will tend to deviate. It will develop amblyopia. So even if you correct it with a proper correction, it may not function anymore if it's caught later on in life.
So a lazy eye can be corrected in childhood,
Yes.
during childhood,
Yes.
and will not recur because it's only common to the infants and
A
children.
sizable amount will be preventable.
Okay. How about floaters? We're going to take a short break. We're going to talk about floaters. I had lunch yesterday, and I had lunch with 3 people. 2 out of the 3 had floaters. So we'll talk about floaters. What are
Okay.
floaters? The treatment and diagnosis when MedTalk returns.
Give your eyes a break. To help your eyes recover, Rest them once in a while during the day. Close your eyes and relax for 10 minutes for every 50 minutes spent in front of the computer. Or find time to take a power nap during your lunch break.
We're back here on MedTalk, still talking about age-related eye conditions. Before we cut to the break, we gave a little bit of a teaser of floaters. And
I have floaters.
You have floaters? Back you have floaters?
I have floaters.
Do you have floaters? Okay, so...
You have floaters? You don't want to review your
Denial.
age. You're in denial.
No, I'm past 40, but I want to know what floaters are. I might just have it. So what exactly are floaters? Apparently it's not that, apparently it is common. Two of you have it. And again, you know, I was with some people yesterday, two of them have it as well. So what are floaters? How do you identify floaters? At what age do you get floaters? Dr. Papa?
So floaters are, usually patients will describe it as parang langaw, these squiggly things that, you know, they're floating in your field of vision, and whenever you move, they move along with it. They're usually the same size and same location. And what it is, they are literally, you know, this is your gel. This is the vitreous gel. It's located in the space right behind your lens. Okay, so in this big space here, this clear, transparent thing, this is the vitreous gel, and it's, you know, it has a lot of collagen, it's made of water, and over time, it will degenerate. So it changes in consistency, it becomes more watery, and when the collagen fibers start to change, you start getting these floaters, as you say. So they're basically just the gel changing in consistency, and when the light shines through, you know, it casts shadows on the retina, and those are the things you see as floaters.
Okay. So is it bothersome?
It depends.
Okay.
If the floater is right at your dead center, then it's bothersome. Sometimes people will do this so that it moves out and you see something and it goes back. Because as what Dr. Papa said, it's attached to some of the filaments. It's literally suspended. It's not a sediment as what we have when we have coffee, wine, it's sediment.
It won't
floats
settle
in.
down.
It won't, because it's still attached at certain points in your gel.
Okay.
So it's literally there. So the definition is floating. It floats around.
Okay, so it's still part of that gel.
Yes.
It's not a detached part of the gel that leaves like a little bit of a hole there. No.
See, that's where you need to differentiate between good floaters and bad floaters.
Okay.
So we were talking mostly about the good floater. So
Okay.
when you say good floater, it means it won't cause any pathology, it won't cause any blurring of vision. It's fairly safe. So you can go through life with that floater around and, you know, you're fine. Whereas you can have bad floaters. So what are bad floaters? Various diseases will present with bad floaters. So if you have bleeding inside the eye, let's say you have diabetic retinopathy, any condition that can cause bleeding in the eye, you will see as floaters. So these dark spots, usually patients will say, from the bottom, umaakyat ng ganon. So those are bad
the bad
floaters.
ones.
Sometimes you have to rule out if there's a retinal hole. So if, let's say, you have a vessel that breaks when the vitreous moves, you can have bleeding and there's a retinal hole. If there's a retinal hole, it needs to be treated, otherwise it becomes a retinal detachment. So those are the bad floaters. So again, you have to differentiate between the two.
Okay, so once you notice, how do you notice if you have a floater? Are there signs, symptoms that you can identify before seeing your ophthalmologist?
So first things first is when you see something out of the normal, one day you wake up or after work, you saw something out of the normal. I think the best thing first to do is to localize it. Left, cover the right, see where is it. So that you can pay more attention to it as the day progresses. Okay. Next is the floater itself. Does it really move? okay, when you do certain motion, or does it follow you? Okay, because if it follows you, then that means it's stuck somewhere onto the retina surface because it doesn't move. If when you move, and there's a delay, like when you shake your Coke bottle and then there's a swirl, okay, then you know it's just freely floating here. So per se, something that follows your gaze is of more concern than something that floats.
Okay.
Later on, then you qualify and quantify how many floaters. 1 or 2 is okay. Sudden onset of a lot is not as good. It can be the bleeding, as what Dr. Papay said. Is it associated with flashes of light? Okay, it's like someone taking a photo in the periphery. Okay, some people would have described it as a small firecracker, baby rocket, curvilinear.
So much activity in the eye, no?
Yes. So when you have those things, those are tractions onto your retina, leading to the retinal hole or tear that you guys alluded to a while ago.
Okay.
So those are the things. Floaters, quantity, where, associated with flashes of light. And of course, the last would be associated with visual disturbance, the drop of the vision. That is actually bad already.
Okay.
And that is retinal detachment.
Okay, so that needs immediate medical attention when your
attention,
vision
yes.
is already impaired.
Yes.
What are the treatment options available for floaters? Is there surgery to take it out? Is it contagious? If the other eye doesn't have a floater, will it transfer to the other eye?
First and foremost, we cannot use the word, we try not to use the word contagious, okay? Because as what we said, it's an age-related condition. It depends on the condition of the vitreous and having its filaments moving around. So let's say you had one here and you don't have one here. Chances are you will also have, but it depends on the severity and the conditions, okay? So your question was on treatment?
Yes.
On the floaters itself,
Yes.
just floaters. Let's say we have confirmed that they are floaters. If it really doesn't hamper your daily activity, okay, reading, doing your stock market things and everything like that, we try to tell the patients, just try to live with it. There's just parts of age-related changes. It is not really a disease.
Okay.
But sometimes there are cases wherein there are too many floaters. It hampers your daily work. Then you can talk about removal of the floaters through surgery. But rarely do we recommend it because at 1 or 2 or even 3, it's practically livable, tolerable, actually.
So how many floaters do you have, Dr. Mo?
1 or 2, something like that.
One.
About 2.
2. So it's livable.
Yeah.
Does it bother you?
I mean, I don't really see them. I tell my patients, you will only see them. I see mine if I stare at a blank wall.
Yeah, white.
And, a blight. But if there's a lot of visual stimuli, a lot of colors, you tend to ignore them.
Okay, so maybe you should have a lot of visual stimuli
Yes.
and not be
Yeah.
confronted with a white wall. Doctors, we move on to cataracts. What exactly are cataracts? And is there a particular age when someone gets a cataract? When someone experiences this?
By definition, the cataract is just, as what we said, in the camera system, you have the cornea, you have the lens. Okay, as we grow old, the lens changes in clarity and elasticity. So first things, it changes in elasticity, wherein it doesn't move, change its shape. That's why you have the presbyopia, inability to focus for near. Later on, because of the changes of the lens fibers itself, they change in color, sometimes become yellowish brown, and that's when you have further dispersion of the light. Isn't it? The more color you have in the lens, the more dispersion of the light is. It's like water with some sediments. When you shine a light, it gets dispersed. If it's clear, light just passes straight. So that in itself is already the early onset of cataract. Okay. Signs and symptoms is frequent change of the glasses, and you want, or it's like you keep on turning the light more in order to see. Those are the most common complaints when the patients come in. And then when we examine them, we see that there are lens changes. When it's young, we know that per se they should occur more in the 60s and beyond. We try to check for any systemic problems, hypertension, diabetes, things like that. So if they're diabetes, we have to tell them to go check your internist for your diabetic control and things like that.
So that's a risk factor, no? If you have
Yes.
diabetes. Are there
If you have different conditions, yes. Steroid use, if you take a lot, certain systemic problems will require the intake of oral steroids. So that can contribute to developing cataracts earlier. So things like that.
The earliest patient who can develop cataract?
Babies.
Babies can develop cataract.
You,
Is that
you can have
congenital?
congenital cataracts.
babies.
Yes.
Okay, so the treatment for babies with cataract is...
Well, idea is to take it out right away. Otherwise, you develop amblyopia.
Okay, so as infants, they can undergo surgery to
Yes.
take out that cataract. If, for example, do you notice that you have cataract already? Or sometimes you just ignore all these symptoms and maybe you just say, you dismiss it and say, I'm just tired, just seeing things, or maybe today malabo lang yung vision ko, tomorrow it's going to be a better day. How do you know? Or do you feel it? Do you see it?
Well, usually the one symptom of cataracts kasi it's smoky vision or cloudy vision. But you have to understand sometimes it affects one eye, sometimes it affects both eyes. So if it affects only one eye, a lot of time the patients don't notice it because they have good vision on the other eye. Only when they go to a doctor and then they cover, kasi we cover one eye at a time to check the vision. Only when we do that do they realize, to their surprise, that, oh, malabo na pala yung mata ko dito. And then when you look in, you see, oh, there's a cataract. So it can be other things, of course, but that's one of the common experiences I get with my patients.
And what is your recommendation to these patients who experience what you've just mentioned?
Well, if it's the right time, then if their vision isn't as good anymore, then surgery to take out, basically you take out the old lens and replace it with a new one.
Glasses cannot cure cataract. You
Not
really have
cure.
to do
At
something.
the onset, insidious onset is because of the changes in your grade. So early on, from let's say, for the sake of discussion, a minus 200, you had a 200 before. It changes to a 300. You just change and everything's still good. So why not? Just have it 300. And let's say later on, after a year or 6 months, 350, 4. So in theory, it should not be going up that high at that rate. So we have to think of other things. So we have to consult with the patient, tell them that you might be having or developing the early onset of the cataract, things like that.
And
So-
your best recommendation would be surgery.
If it is functionally preventing him to do his daily chores, let's say depth perception is very important to the patient. Okay, so you have to talk about that. But if he just sits down, listens to the radio, doesn't even watch TV, it depends on the patient already. But if someone is like what runs the stock markets and things like that, you have to also talk to them. And maybe he wants to recover that vision back earlier than later.
Okay. It also depends on the patient, no? What
Yes,
the
not-
lifestyle of the
yes,
patient
yes,
is,
exactly.
and if the patient is willing to undergo surgery,
Yes.
or maybe just keep changing
Yes.
your grade
Nowadays,
every
kasi
year.
it's not really you used to hear the term pinapahinog, or we wait for the cataracts to mature.
Yes.
You can still do that, but again, as mentioned, it depends on how the patient lives, the lifestyle of the patient, how much he needs his eyes. Let's say a pilot will have, he will need 20/20 vision always. So even at, let's say, 20/30 vision, he may have the cataract operation done already. Whereas someone who has a more sedentary lifestyle, as mentioned, even at 2100, pwedeng, doc, I'll just wait a few more months, a few
Pahinugin
years.
muna.
Yes, so
Okay.
you have to talk to the patient and determine what he really wants.
Okay.
Depends.
So when we come back, you mentioned talk to the patient, determine what the patient wants. When you're over 50, what does the patient want when one has age-related eye conditions? Surgery? Will they go with their eye drops? Will they just use glasses and change the lens every year? We'll talk about that when MedTalk returns. We're back here on MedTalk, still talking about age-related eye conditions. So doctors, over 40, you have your presbyopia, your nearsightedness, farsightedness. You have that. Over 50, 60, 70, what eye-related or age-related eye conditions will one have? Dr. Papa.
Okay, well, we mentioned cataracts already. So there's also another a condition that's getting to be more common nowadays, which is macular degeneration.
Okay.
Now, it's not really, over 50. Usually, the patients who get it are, in their 60s, 70s. So the older you get, so it's a risk factor. The older you are, the more likely that you will get the condition. As the condition's name implies, it's age-related macular degeneration. So that's another condition that's becoming, fairly common nowadays.
So you've diagnosed a lot of patients over 60 with age-related macular degeneration. What exactly is it? What happens to the eye, and what particular area of the eye is affected?
When you say the age-related macular conditions, first and foremost, it is actually the retina that is involved. So there's the peripheral retina, the central retina. Okay? So when we say the macula, it is the area where we focus. That's the point that where we really have sharp focuses, we call the fovea. So, but suffice it to say, we just talk about the center region, which is the macula. So it's somewhere here. Okay? When you have any problem here, and more often than due to age, we term it as age-related macular disease. Okay? There will be doctors who would say there's the dry type and the wet type. The dry type being a very slow onset. Okay? Very, very slow deterioration to the point that we don't even do anything about it. But we try to monitor them, okay? Because sometimes they can convert to wet, or what we call wet or weeping. When you say weeping, it leaks or it bleeds all of a sudden.
Okay, is it manifested through tears when it's wet? No?
No. When you say wet type, so tears are completely different from, it's not something the patient will feel. So the wet type of macular degeneration refers to the lesion involved in the macular degeneration itself. So there is something known as, there are new vessels that are coming out from a structure in the retina. So it's called choroidal neovascularization. So neovascularization just means new vessels. So there are new vessels growing, and that's why it's called the wet type. And this is the type of macular degeneration that is treated as compared to the dry type.
Okay, so is the wet type more common than the dry?
No, dry type is more common. It's
the dry
about
type
90%. So only 10% of those of the macular degeneration patients are of the wet type variety.
But the wet type is the more devastating.
Yes.
Okay.
Isn't it? Imagine a sudden bleed. So that's what you said a while ago, a floater. I said you determine it to be floating or a stationary spot. So when you have something bleed or leak, you have a stationary spot or area that whatever you do, it's blocked.
Okay.
And it's right at the center. So
it really blocks your vision.
It literally
talaga.
blocks your center vision.
How about with the dry type? What happens to your vision?
The dry type, it's again, as mentioned, it's usually gradual. And the vision is fairly good. So let's say the normal vision is 20/20. You can get visions 20/30, 20/40. So it's not really debilitating. Whereas with your wet type, if left untreated, they can go legally blind. So up to 20/200 or even hand movement or counting fingers.
Okay. So do you have to treat this right away?
Well, the best time to treat wet type of macular degeneration is early because we tell the patients that sometimes we are trying to prevent deterioration. So it's not really to get you back to your original vision. So the best time to treat it is when there is vision that is still worth saving. So early on.
Okay.
The logic wherein why it's early on is, as what your animation is showing, is that while you still have developing of those abnormal blood vessels, they're still of small caliber. They're easier to treat rather than when they're already more mature. Okay. It's like a tree trunk. I mean, the roots. The smaller roots are easier to kill rather than the big ones. Okay, be it laser, injections, or surgery. It's always easier before they get a very good stronghold of your remaining retina.
Do they become calluses in your eye? It's like the stronghold.
Well, they become scars or they form membranes, so not really.
Not really a
calluses.
callus, no. I was imagining like, it becomes
But
so
I
thick
think
and it becomes a callus already.
Same principle. It will form membranes, and eventually, even if you treat it, because it's a scar, because there's a permanent membrane underneath, you can't treat it with medication anymore.
But those treatable with medication, what type of medication? How often? Should you be religious in doing the medication so that you won't get your vision back to its 20/20 state, no? But it can help with the vision at that age already.
Yes. In treating, back when we were still med students, it was just form of laser therapy. We ablate whatever blood vessel that is, we just kill it. But the thing is, it's treating that scar-forming thing with a total burn so that you cut it immediately.
It's like the roots that you mentioned.
Yeah,
no?
you cut it immediately and that's it. But which is actually good. Even up to now, it's part of the treatment is still with that laser. Okay. Nowadays, what we do is we give injections we call anti-VEGF, which is anti-vasoendothelial growth factors. As what your animation has shown, abnormal blood vessel formation. We give anti-VEGF to sort of reabsorb this one. So when you regress this one or somehow control or curtail the growth, you contain the problem or the drop in vision. So it's almost like lasering also, in a milder way. So there are other medications, but there, aside from anti-VEGF, you can also use steroid injections or a combination of both, depending on the size, the type. Okay, but as I said, there is a protocol. It's not a one-shot, do-it-all thing.
Yeah,
They
maybe
have to be
one shot
monitored.
and then after 4 years you come back. And
Actually, it's not like that.
No, actually,
it's not like
he
that.
He can explain to
You know, the unfortunate thing about wet AMD treatment, it's not like cataract, you know, after you remove the cataract, you know, okay, goodbye doctor, I'll see you, you know,
you
we're
when I
done.
see- yeah.
But for AMD, wet type, you give injections almost every 4 to 6 weeks. And that's continuous.
for how long?
Well, ideally kasi tuloy-tuloy talaga eh.
For life?
You can try and...
Until you have stabilization.
Yes. If
Okay.
sometimes kasi, well, the studies they did 2-year studies na every 4 to 6 weeks, injection. We try and extend treatment. You know, you give a loading dose every 3, every 4 to 6 weeks, and then you try and extend it. Kasi the meds aren't that cheap.
Okay.
So, you know, here we try and extend it, but then if it starts to, we've found that it will regrow again. The vessels will start to emerge again, so you have to retreat again. And if the vision starts to go, sometimes you don't recover that vision that you lose. So the ideal talaga is really to monitor, and if the lesion is still wet, so to speak, then you continue the treatment. The end point kasi is when it's dry.
So you really have to be religious in getting those shots.
Yes.
Drops will not do it.
Drops won't, unfortunately.
They're trying
trying
to
to
do
look
some
for-
research. Most probably the drug companies and other scientists are trying to do some research wherein the mode of giving the medicine will be through drops. In that way, we'll be able to cover a lot of patients. But up to now, it's still in the drawing board, most probably.
But patients actually get scared of the thought of a needle.
Yes.
It's actually, we use a very small gauge
Where is
needle.
it injected?
We measure an area from the so this is the limbus, and we measure an area about 3 millimeters from that area and inject it directly. We need to put the medication in here, into the
Okay.
gel area here. So it's a very small needle, and you know when they do when you're
IV?
in the hospital,
Yes.
that hurts even more.
Yes.
So
Oh,
this
really?
is
Oh,
very,
okay.
you know, it's like a little prick of an insect
That's good
in
to
your
know
eye.
that it's the IV is
Actually, some patients would
parang
even
more
say
bothersome.
that the sting of the eye drop is even
Hurts
more.
more.
Oh, okay.
So usually by the second, third
Okay, that's
injection,
going to
wala na.
appease those who
Yes, it
are
does.
watching who may have AMD and would like to undergo the treatment that you've mentioned.
Because that's their biggest fear, more than, you know, if they'll get better. Dok, masakit yan, injections.
So hindi
It's
siya
not.
masakit.
No,
It's not painful. Okay. When we come back, we'll talk about diabetic retinopathy. We've been talking about that for the past 20, 30 minutes. So we'll get to know more about diabetic retinopathy, the treatment, and what age group is more prone when MedTalk returns. So,
Studies suggest that munching on green leafy and yellow vegetables can help prevent age-related eye problems. Antioxidants that mainly come from sweet potatoes, pumpkin, dark leafy greens, and egg yolks are also known to be effective in protecting the eyes against the sun.
We're back here on MedTalk, still talking about age-related eye conditions. This time, doctors, let's talk about diabetic retinopathy. Did I say that right?
Yes.
Okay.
Yes, I think you did.
So please tell us what is diabetic retinopathy.
So
Dr.
diabetic retinopathy refers to changes in the retina that are brought about by diabetes. So it's not really an age-related condition because what are the risk factors for getting diabetic retinopathy? It's usually the length of time that you are a diabetic and the control of your diabetes. So it means that the longer you are a diabetic, the more chances of you that you will get diabetic retinopathy, in the same way that if your blood sugar remains uncontrolled, if it fluctuates too much, then you will get diabetic retinopathy earlier as well. So we just tend to see them when the patients are older, I think because one, they did not have early monitoring of their eyes when they were initially diagnosed with diabetes, and two, they usually will not go to the eye doctor unless there are visual changes already. Yeah. So that's why they are detected later on. But ideally, once you're diagnosed with diabetes, it is best to have yourself seen and checked by the ophthalmologist.
Yes.
The best is to have a baseline, actually, once diagnosed with diabetes. Because number one, once diagnosed with diabetes, you're actually what? 2 or 3 years back that you already had the diabetes. More often than not, in the Philippine condition. So we have to at least have a baseline retinal exam. And from there, we gauge as we do it once every 6 months, once every 2 months or 3 months, depending on the diabetic control. And that's what you said, hypertension is a risk factor in the retinopathy, also the cholesterol levels. Okay. Aside from the blood, the hyperglycemic control of the patient.
Kasi all diabetics will get diabetic retinopathy. It's just a matter of time. All of them will. It's just a matter of time. When will they get it? So literature will say if you're on good control, usually after about 8 years, that's when you will start to develop it. But if you are not on good control, then you will get it earlier. And plus, when you were initially diagnosed, as Dr. Go mentioned, you don't even know that that's not time zero. Pwedeng yung time zero mo is years earlier. So you won't even know that.
So you have to catch up on all those years na hindi ka na-diagnosed and you weren't treated.
Yes.
So what is the treatment? Oh, wait, before we go to the treatment, what are the symptoms that will manifest if one has diabetic retinopathy? What happens to the eye? What kind of vision is impaired?
For me, the mildest would be the inability to focus. Almost like for young patients, it's almost like the presbyopia, inability to focus, because diabetes itself will also affect the lens. Okay, so that's the reason why when we said that cataract, it can happen early. If it happens like 40 plus years old, 50 plus, for no apparent reason, no trauma, no family history of young, you have to think of diabetes.
Okay.
The retina would still be good, but you might see some changes of the lens to have some streaks of opacity already. So then later on, you have some minor leakages or bleed. You have a drop in your sharpness of vision and in your contrast. Let's say at night, you'd say that you have hard time driving now at night. Or your movie watching at night is not as good, not as pleasant as before. Something like that. So those are the early things. Then later on are the obvious changes. Really a drop in vision, okay, a sudden floater again. Okay. Those massive floaters, it's like a rainfall of bleeding. That's what Dr. Papa said.
But sometimes the patients won't have symptoms. So they come to you, Doc, I'm okay. You check the vision, it's 20/20, but then you look in, you have a lot of bleeding already inside. You're a bleeding event waiting to happen. So, sometimes they're not that severe, but the point is you can develop diabetic retinopathy even without the symptoms. So it's your
Just the
doctor.
mere fact that you're diabetic.
Yes. So it's your doctor who will be able to tell you at what stage of diabetic retinopathy you're at and what management that you need.
So depending on the stage,
Yes,
the
that's it.
treatment also
Yes.
will be different.
Yes.
So what is the more common, or what's the more common treatment here in the country for those with diabetic retinopathy?
First things first, we tell the patients that hyperglycemic control is really a must. Because whatever treatment you will discuss with the patient later on will just go to waste if you don't have good glycemic control.
Okay.
Okay, so from there, we do what we call an angiogram. Okay, if we have an angiogram for the heart for looking for blockages, the reverse is true in the retina angiogram. We look for areas of leakages. And depending on where the areas of leakage are, if they're accessible for laser, we can laser.
Okay.
If they're accessible for injections to decrease,
Which are not painful, by the way.
yes, and very dramatic results, okay? We discuss it, or we do a combination of both, provided there is always a background knowledge that hyperglycemic, hypertension, cholesterol control is mandatory.
Okay.
We're actually trying to, the VRSP, or the Vitrio Retina Society of the Philippines, of which we are both part of, we're trying to hammer out an agreement with the Endo Society for better referral system, meaning for the ophthalmologists to refer to the endocrinologists, and for the endocrinologists as well, for a better overall care of the patient, because they need both.
It's like when you have a first catch of that patient, you refer it immediately, and when they have the first catch of a virgin case of a diagnosis of diabetes, they refer it for baseline monitoring already.
Yes. So hand in hand, no?
Yes.
You cannot just treat one and then
You have to
expect
treat-
the other to be healthy and okay, you know.
Yes.
All right. How about glaucoma? What treatment does one have for glaucoma, and what is the difference of glaucoma from all the other eye conditions or age-related eye conditions that we've mentioned? Dr. Go.
Basically, by definition, glaucoma is let's start it this way. The eye, in order to maintain its shape, has to have a pressure. So much so like a tire. It has an optimal pressure. So by definition, we label it as from 10 to 21 millimeters mercury. Okay. So anything above that is labeled glaucoma. Another definition is sustained rise in pressure causing damage to the nerve. So because when you have damage to the nerve, there's a drop in vision. So that is, I think, a more accepted definition of glaucoma. Any sustained damage. Okay, because when we go to the nitty-gritty of glaucoma, there are some damages even with low pressure. As long as there's nerve damage, it is termed glaucoma.
Okay. Okay. So you mentioned the pressure.
Yes.
Do you feel the pressure? Is it like ticking, or is it like when your eyes are so tired and it beats?
No, there's none of that. If you're within a certain pressure range, usually you won't feel anything unless it gets into the really higher pressure numbers, let's say 40, 50. But it also depends on the pain sensitivity of the patient. Because I have some patients, their pressures are 40,
but they
parang
don't
normal
feel
lang, they don't feel it, which is scarier because then they won't know
Asymptomatic.
that there's something
Yes.
wrong. But some patients, they'll feel, there's something throbbing, there's a pain in my eye radiating to my head. They'll go in, you'll check, and the pressure is about 40 to 50. So there's obviously glaucoma happening there. And you need to treat that right away because you need to bring the pressure back down to 10 to 20. Otherwise, you're going to cause permanent damage to the optic nerve. And it's irreversible. Because glaucoma there's no cure. You can only, again, prevent deterioration. You can only try and preserve the vision that the patient has so that the vision will last for as long as the patient will last.
So you mentioned it's asymptomatic,
Yes.
and then there's a radiating pain,
Yes.
like a headache.
Yes.
We
Those
often,
are more for severe glaucoma.
Okay,
Yes.
because we often identify a headache with something wrong with the eyes.
Actually, all these symptoms are non-specific
Non-specific.
signs and symptoms. I
Okay.
mean, any condition can cause the headache, the eye
Right,
pain. That's
right.
why the patient needs to be assessed. If there are symptoms like that, then he needs to be assessed. So sometimes a migraine can give those symptoms. So the patient goes in, we check them up, everything's normal. So it may be a migraine. So I send them to the neurologist just to rule out other problems. So basically a good checkup will do wonders for the patient.
Okay.
So when you check them up, usually patients will say, Doc, my left eye or my right eye is a bit heavy. Those group of patients are very sensitive to any pain. So they're actually good in a way, okay? Because you notice that there's something wrong, you sort of localize that area already. Then you check pressures, and then you notice one is slightly elevated. You look at the normal structures of the eye. Something is a bit off from the normal that we see. We can do nowadays a good glaucoma screening.
Okay.
So that in itself will at least give us a good profile of that eye versus the other eye, and see if there are really early changes for glaucoma. Okay, because back in those days, we were only able to do pressure monitoring and gross changes. Nowadays, with the advent of technology, we can do early detection of very early nerve damage. So to do a glaucoma screening is nothing. If the kids nowadays are so used to playing games, it's like literally like playing of a game, or something like sparkling of lights, doing a scan. From there, we are able to detect early, and we are able to educate them early enough. So that should be good.
Early detection really is key. We
Yes.
always say this on the
Always,
show,
yes.
no? Always. Don't
For, I
wait
think,
for
most
the...
diseases.
For all...
Unfortunately.
Diba? Unfortunately, but for... it's also the responsibility of the patient to monitor some odd activity happening to your body. In this case, the eyes, no? Sometimes...
But that's the most here. What we get only when there are changes. Now that's when they
Yes,
start
they're
to
late.
consult.
What are the treatment options available for
glaucoma.
someone who's glaucoma? And is it genetic? Like, for example, your parents have it? Is it automatic that you will have it?
If you have a family history of glaucoma, it's a risk factor. So it means that you have a higher likelihood of getting glaucoma as well. So for treatment, doctors will initially start with topical drops. So you place drops that will lower the pressure. You can give oral medications also to lower the pressure. If these things don't work, then they proceed on to laser therapy or even surgical management.
So there's also like a
Yes.
protocol to follow. Which of the treatments you think will work best for that particular patient with a particular complaint?
glaucoma, yes.
Okay. Doctors, is there a screening test for individuals over 50 that they should get every year together with their checkup? Just to
good
make
eye
sure
exam.
their eyes are in tip-top shape?
A good eye exam with a complete retinal exam, I say that would be good. It will
Yes,
cover
because-
everything already.
Okay.
Yes, because when you say it's a good eye exam, it's really from the front all the way to the back. That's it.
Over 40 na rin. Let's include those
And
over 40.
actually,
Actually, any age, no?
Any astute ophthalmologist would always and will always examine the patient from the lids to the cornea all the way to the back.
Okay.
No exception.
Because a good eye exam, you will be able to detect if, you seem like you're having glaucoma, or
You're at
I think
risk,
you're having a
something like
macular
that.
problem. So from then on, they will request for other diagnostic procedures to confirm the diagnosis. So a good eye exam is, it's good enough. You don't need to go and have all these tests without, just for the
So
sake.
your basic eye exam will do, and then take it from there.
Yes.
And then see your ophthalmologist.
Yes.
Vision is so precious. It's fun. It's exciting.
No,
and-
I always say vision makes you appreciate life.
Yes. Oh,
That's the only
true.
thing. That's the only
true.
thing, actually.
So you've helped us appreciate life a lot better, Dr. Go, Dr. Papa. Thank you very much for your time and for making us see
Thank you
that
also.
we really
you.
need to take good care of our eyes. All right, we'll see you again next Tuesday, 7 p.m. here on MedTalk, your scheduled on-air consultation on 9TV. This is Angel Jacob. Good night, everyone.